as far as I remember, I would like to say a few words how I was involved with menopause practice. I started my one hospital in 1988. In those days, coming across so many work of obstetrics and infertility like that. In 2020, my husband started one clinic in other area, and I also used to sit there. In that area, I used to come across a little bit elderly people, and then just I felt that I should be aware of everything for treating this age group of the people also. And at that time, my madam, Dr. Devendra Ben Shah, had just attended one conference at perhaps Hyderabad only of Indian Menopause Society. And she inspired me that, Anista, you should start menopause chapter in Surat. And from that, I just started the menopause chapter of Indian Menopause Society Surat in 2006, just after 1 month after Sudha started in Jammu. 2004, sorry, 2004, yeah. And after that, in 2006, we started Club 35 Plus. And since then, I can say it was passion for me to just get involved with Menopause Society. And as you all are knowing that our Indian Menopause Society, it is an extended family. Of course, in the early age, there were very few chapters, and we were so close to each other that we were knowing each and everything about everyone. Of course, now it has become just like a big banyan tree. We are having 52 societies and more than 5,000 members. Then also we are connected to each other very nicely. After that, Corona came and we just became digital. And in those days also, we used to meet in the morning, afternoon, evening, at night. In the morning, we were at Jammu. In the afternoon, we were at Surat. In the evening, we were at Jaipur. And at night, we were at Bangalore. Like that, we used to talk with each other and we remain in connected. So now, as you all know that in the era of science and technology, of course, younger generation are more interested in infertility and endoscopic practice. But at the same time, we also need a lot of proper knowledge regarding the midlife health of a woman. And that's why menopause practice is of utmost importance. For that, we are having CIMP exams that we are just taking every year. Previously, we were just finalizing it at the time of conference in the physical form. And after Corona, we also made it digital. And so the many students and many gynecologists are getting involved in that, appearing for that exam. And all of you are knowing very well that our clinical practice guideline is just like our Bible of menopause practice. It has a very well versed, and so it gives you a total updation of this our practice. Similarly, menopause clinic, we can say that it is a need of an hour. Of course, it doesn't require a lot of extra instruments or extra things or extra expense. You can just in your clinic only, you can spare some time and you can do everything at that under that shelter only. Of course, you need a little bit time for that. You can't just take the patient on the table, listen the FSS and do the pulse BP and just take it out. You need a proper counseling for both the partners. And I think Dr. Ragini will tell something more regarding that menopause clinic before we starting this prescription writing of today's webinar. Ragini, please.
Thank you, Dr. Anita. Now I would like to invite our secretary, Dr. Ragini Agarwal, for her pearls of wisdom on bone health and menopause clinic.
Thank you so much, Reena ji. Very good evening to one and all. This program, which is being run by the Indian Menopause Society, has only one motive, that we should all well versed how to write a prescription of menopausal women, which is a very important thing, as Anita ji has said, that it is a need and hour, and we all know globally the age is increasing, and almost more than 25 adult years of the adult life we are having in this period. So our OPD is going to be full with these patients, and we have to do the justice. And in this, there's not many, even the gynecologists are well versed in the menopause. Many a time when we go, the gynecologists who are attached with the Indian Menopause Society and having the workshops and the teaching of the Indian Menopause Society, they know how to treat these patients, what to ask. But most of the cases, it is really pathetic. They are so scared of even writing the MSTs, and everybody has a lots of problem. So, but until unless we will, as Antaji has said, we are really, CIMP is one exam that we have to follow. And in this clinic, our dedication towards these aged women is really necessary. They are different from the reproductive age. Their need is different from the reproductive age. And they are not geriatric. They are not in the reproductive age, but they are still young. They want to have a quality of life. And quality of life only they can have if they are healthy physically, mentally, and socially. So all these three factors we have to see. We have to understand that the menopause transition is the period when we have to prevent. And when she entered in the menopause, this is a time of rejuvenation. And then when she become a more elderly woman, 65 plus, entering in as a young geriatric woman, she need a restoration. So menopause clinic, just like a IVF clinic, just like a you can say laparoscopic hospitals, we really need, really require these menopausal clinic to take care of these women. And it is in my mind, maybe you have all got my that booklet where I have written how we should have a menopause card. Maybe this year or next year in the Sudhaji's year, we will come with a concise form of menopause card where we can have a direct question from the patient why she is visiting from the clinic, what complaint she has, whether she has come to ask for the preventive care, or she has come to understand what is menopause is. And then we have to go in the detail of the menstrual history, family history, medical history, and all those sexual history, and then the general examination. Here, breast examination and breast awareness, pap smear, these things are very, very important. And we have to look for her some important thing at this age, whether she is developing thyroid again, whether she is developing diabetes, and the bone health. No doubt, bone health and the sarcopenia, what we called as a musculoskeletal syndrome, that is very important. Any elderly woman, the first thing is gone is the muscles. It's not even bone, muscles. And the moment she has developed the sarcopenia, she will not able to move so much, and the rate of the loss of the bone loss will be increased. So we have to talk about the musculoskeletal syndrome in toto also, and focus on this. And in the many country now, in early stage with the window of opportunity, they are saying if the patient is put on the MST, she is going to get a better response in the musculoskeletal syndrome. And we are having the guest speaker today. Thank you so much for giving me time, and we will continue with our guest speakers today. Thank you so much.
Thank you. Thank you, Dr. Ragini. And hope all of us have had the message that we should work separately for these women in midlife to the menopause for their preventive as well as treatment strategies that should be taken separately, and we should have a concern about it. Thank you for your nice pearls of wisdom. Now we move on to the next session, that is diagnosis, treatment, follow-up, and preventive strategies in midlife women with osteoporosis. For this, I would like to invite Dr. Shankar R. Kurpad. He is very well here. Welcome, Dr. Shankar. Paresh, may I have his CV?
Shankar, welcome. Dr.
Thank you,
Shobha
ma'am.
here.
Welcome,
Thank you
Dr.
so
Shankar.
much.
He is
Thank you all
alumnus
so
of
much.
St. John's Medical College, CMC Vellore, fellowships in traumatology at Germany, hip joint replacements and revisions, complex hips at Germany. No, we need to know you nicely. He is consultant orthopedic surgeon at Bangalore, special focus on complex periarticular trauma, osteoporosis, and osteoporotic fractures. That is very good for today.
Varun
Bone
sir
and
पे
joint
धाको. Right,
hips,
doctor.
knees, joint replacements, and joint revision. So, welcome, Dr. Shankar. Please, you are invited for your session.
Thank you. Thank you all for having me on your program today. It's an honor and a privilege to be part of the team. And it is very humbly that I responded to the invite, saying that I know very little about this, especially hormone replacement therapy. And I was told by your team members that don't worry, you talk about what you know, we will deal with the rest. And I think that's a very important point that I actually will go back to later on in my talk, which is the very fact that the management of osteoporosis is actually a team effort. It is impossible in today's day and age for only one individual doctor or surgeon to deal with this very complex problem. So without much further ado, I do hope my screen is getting shared. So at the outset, thank you all for this opportunity. Over the next few minutes, I'd like to share with you what we have been doing as orthopedic surgeons, and I speak for myself, my team, and my colleagues who have had some exposure to osteoporosis and its manifestations. Now, the greatest challenge that we face when we are faced with an osteoporotic person who's coming in with a fracture is all of these things, and they occur at the same instant. It is nothing planned. The patient didn't plan for the fracture, the family didn't, and definitely we didn't. We may be better equipped to deal with the problem, but none of us really plan for a fracture to land up in our OPD. So we are always there, just like how any first aid involves ABC. Similarly here, keep the patient alive, make sure medical management occurs. The surgical challenges have to be dealt with. Keep the patient mobile, and that is extremely important because the multidisciplinary uh, you know uh, effort that is required has to be there. And very importantly, this last issue, which is trying to ensure that the patient doesn't keep coming back with repeat osteoporotic fractures. Now, most orthopedic surgeons unfortunately tend to focus on surgical treatments. That may be to some extent at least, the sort of training issue that happens at least in our country. But if you look at it across the planet, there is definitely a gradual increase awareness of osteoporosis, the sort of medical treatments that should be occurring there. It's not just about fix the fracture and forget about it. It's not just about trying to help the fracture to heal and then forget about it. The most important part of the fact that we are doctors has finally come back full circle because we ultimately have to prevent problems and actually participate in educating our patients to make their health better. Now, we are all sure of this, that osteoporosis is this. It's a net decrease of bone per unit volume. And we've got problems with collagen as well as mineral content, bone remodeling. And as like the previous speaker did mention, there is an associated problem with muscle mass, which probably antedates or occurs slightly before the osteoporosis becomes evident. That is true. And if you add to that the fact that a lot of people with osteoporosis also are concurrently low on vitamin D, the vitamin D being low is a very damning factor to both sarcopenia as well as osteoporosis. Now, obviously, once there is osteoporosis, you have more fractures, you have an enormous burden on everybody. Now, the WHO criteria, based on DEXA scans, revolutionized the ability to pick up osteoporosis. It's a screening tool. It defines what is osteoporosis and differentiates on a scale what is normal bone, what is osteopenic bone, and what is osteoporotic bone. To that extent, yes, it has revolutionized our understanding of osteoporosis, our ability to apply that into the general population. However, it does not linearly relate to the risk of fracture. That is where the FRAX tool from the Sheffield University, as you're all very aware of, makes a big difference. So the FRAX tool is what we should be using to actually assess fracture risk. Now, this again is kind of old hat in the sense everybody knows about this, but very often, it's so basic that sometimes people miss a couple of steps. So let's go through it just to make sure that nobody misses these steps, because every single patient who walks through the door with potential osteoporosis should have these steps sorted out. We need to have a see, when the patient walked into the door, they're already at step 4. They're coming and talking to the doctor. So it's our job to ensure that the first 3 steps have already been sorted out. That is, that there is adequate calcium and vitamin D that the patient is taking. If there is a shortage, if there is a need for supplementation, let us supplement it. Exercise has to be emphasized. An active lifestyle is good. Exercise on top of an active lifestyle is excellent. Let's focus on that. Smoking. This is a binary situation. It's a 0 or 1. One either smokes or does not smoke. There is no question of, oh, I'll reduce my smoking from 1 packet a day to 1 cigarette a day. That doesn't work. Smoking is a binary issue. Let us stop smoking. Alcohol, yes, there is a graded response of the body to alcohol, at least with regards to osteoporosis. So probably moderation may be okay. But then literature has been coming out time and again, which has been telling us that all alcohol is problematic. It's just a question of whether you have less problem or more problem. We have to recognize that a lot of earlier literature has been Western based, and because of the social context of the fact that alcohol is a very frequently consumed, socially accepted thing. It's like, tea, coffee in, let's say, in southern India. It is very commonly used. Therefore, it is very difficult for them to write against alcohol very bluntly. That may be the reason is what we are recognizing nowadays. So the tendency is, let us relook at alcohol. If possible, let us minimize or avoid it. Now, appropriate medication. We are here to discuss that. With age, we'll end up in trouble. Now, apart from the fact that there are multiple risk factors that are going to reduce bone mass, let us also remember that there are increased propensities to fall. Now, you could very well use vitamin D as an archetypal example where it affects both. It affects bone mass and, very importantly, increases the propensity to fall. So if you ever find vitamin D being low, let us quickly jump on it and quickly treat it. Let us not say that, let's use some sunlight or whatever. Please treat it appropriately so that the tendencies that vitamin D has for worsening of fall, sarcopenia issues, osteoporosis issues, all of that gets brought under correction quite quickly. And of course, all your other therapeutic medications that are dependent on trying to work on the anabolic aspect of bone would fail miserably if the vitamin D is actually low. Now, if somebody has a fall, they have a high risk of another fall. This is the principle of what we refer to as secondary prevention. Now, the greatest, what shall we say, the sad part with osteoporosis is that it is extremely silent. By the time that most people come with osteoporosis, they are presenting with the fracture. That is the most common way in which people are picked up with osteoporosis. It is not because of some routine screening program that happens in the local Mahila Mandali or the apartment block. We have to recognize that the greatest pickup of osteoporosis happens after a fracture. Therefore, it is incumbent upon us to try and figure out how to reduce the risk of a subsequent fracture. Therefore, if you refer back to the heading of our talk, it includes prevention. That prevention is not primary prevention. That is secondary prevention. In middle age, we have missed the bus as far as primary prevention goes. Primary prevention basically is, youngsters. That's where you need to focus on that. Increased nutrition awareness, calcium, protein, vitamin D, exercise, load-bearing exercise to build mass. All of that makes a difference for youngsters. Improve the peak bone mass. In middle age, you may have missed the bus with regards to many of these things, but let us remember that bone is a live tissue, just like muscle. You improve activity, physical activity, you give it the necessary building blocks, it will build. But obviously, it cannot build like an 18-year-old. It will build like, let's say, a 55-year-old. But that's better than nothing. So there is definitely a value in focusing on the first 2 points of the National Osteoporosis Foundation issues. That is, focus on calcium, vitamin D, and nutrition, and look at exercise. Don't forget those issues. This is the, what shall we say, the demon of osteoporosis, the osteoclast. And this massive giant cell with its amazing ruffled border is capable of eating into the bone under the effect of various circumstances. Let's not blame only hormones here. It could be various circumstances that result in osteoclasts running amok and worsening bone quality. Now, this is a sort of synopsis slide of how estrogens are supposed to act on controlling the osteoclast activity. And of course, this is something that I picked up from somewhere. And honestly speaking, being an orthopedic surgeon, my ability to explain to you what these various acronyms mean is actually very limited. But what we all need to understand is that the ability of our knowledge to intervene at certain key steps in reducing the tendency to go towards a mature osteoclast exist. So there are decoy receptors that we use, denosumab, for example, is used to ensure that mature osteoclasts don't happen, and therefore that's one of our modalities of treatment with regards to osteoporosis. Now, the question is, who needs to be screened for osteoporosis? Does everybody who's middle-aged, do they need to get screened? The answer is honestly no, and it needs to be refined. Now, the first line there is basically outside of today's syllabus, in the sense today's syllabus is discussing the 50 to 65-year-old person who comes into, on a routine review kind of situation, either to the OBG clinic or to the orthopedic clinic. So there are few history factors that decide whether somebody is at a higher risk of fractures. What's the family history? Now, most of us in practice do have actually family practices. For many of you who are in the OBG practices, you may be delivering the third generation of their family in your practice. So when these sort of things are there, there is the ability for you to be in contact with people in their 60s, people in their 70s, people in their 50s, and people in their 20s. So the ability to see through generations, you have the ability to know who in that family has osteoporosis, and that history has to be plugged into the person who's sitting in front of us. Now, fractures after the age of 50, any fracture after the age of 50 needs to be looked at with the lens of whether this could be an osteoporotic fracture. Was this a trivial fall that caused the fracture? That's the historic point that you want to question. Other medical conditions. Diabetes is an interesting problem because A, in India, we've got an enormous diabetes burden, and B, diabetes unfortunately tends to coexist with osteoporosis. Whether it's causal or not, I think the debate is still going on. Rheumatoid arthritis, a whole lot of other rheumatological conditions, they've gained a lot of traction post-COVID vaccination. You get patients telling us that after COVID vaccination, suddenly they discovered to have autoimmune disorders. That whether that is related or not, debates out there, but we do have a large number of patients with these issues. Loss of significant height. This is an important point. The moment somebody comes to us talking to us of, we are feeling a little, everybody's telling me I'm a little shorter than what I used to be. Let's get an X-ray done. Let's see what the spine looks like. Let's make sure that there aren't any missed thoracolumbar cracks or collapses. Smoking and alcohol. This is far easier to deal with male patients. It is a very touchy subject for women patients. I personally find it very challenging to have an honest discussion with anybody about their consumption of alcohol, the need to stop alcohol, the need to stop smoking. It's a very challenging discussion. And unfortunately, the reality is in India, the discussion tends to head the way that the patient believes that we're trying to stigmatize them. that probably means that we have to be very careful in wording it. It's very important to guide the conversation in such a way that they come out and tell us that actually I am consuming tobacco. Um, and then it's fair enough to then work on that and then say, okay, now, actually there's a lot of literature out there that tells us that tobacco is not good for us. I mean, we all assess our patients and we then decide whether we're going to go the literature-based discussion route or whether we're just going to talk about safety. So whatever be the way, the discussion is obviously individualized, but that's an important point to hit. Steroid use, whenever possible, stop steroid use, because throughout life, steroids unfortunately keep eating away at our bone quality. Now, similarly, antiepileptics, there are a whole lot of patients who've used antiepileptics, let us say after road traffic accident, head injury. They've been told to use an anti-seizure medication for 6 months because of the head injury, but they have never reviewed and they continue to use antiepileptic medications for years together. The net negative on the bone is significant. Chelation agents is not very commonly used, but remember that there are so many thalassemics out there. There are so many other patients who are using chelation agents. So be aware that these things also chelate, apart from chelating ferrous ions, they also chelate calcium. Just like how morbid obesity is a problem, low BMI is a problem. Both are examples of malnutrition. And definitely, please go through the causes of secondary osteoporosis. The DEXA machine is the favorite way to discuss or pick up osteoporosis. And I'm sure all of us go through these things and all of us understand that osteopenia basically means that the T-score is below -1 and osteoporosis statistically derived for that population. The patient's T-score is below -2.5. Now the FRAX. This is a screenshot of the old website, and I honestly loved the old website. It just was more visually appealing. The present website is this, and let's face it, this looks better than this. But we are not here to discuss which website looks better. It's about the question of what's more effective. Now, this current website has the ability to look for more of these problems and plug in more points on the into the database system, so you're able to refine the risks. Even if you don't have a BMD for that patient, it's fine. The prax is fairly accurate even without the BMD. With the BMD, you are literally pinpointing the patient's risk. Now, with these things, what I've plugged in there, you've got somebody who's obese with a BMI which is probably around 30-ish, and with a previous fracture, one parent with a fractured hip, has taken glucocorticoids in the past, um, you know, has some features that suggest secondary osteoporosis. We've got fracture risks that are very high. So major osteoporotic fractures over 20% is a problem, and a hip fracture in the next 10 years at greater than 3% is a great problem. Now, these are very important things to remember. I keep getting asked about, don't you do any blood tests for osteoporosis? Can't osteoporosis be picked up by blood tests? The reality is that it can't, you know. So what at all do you do blood tests for? There are certain markers that you do basically to assess whether your treatment is going on in certain scenarios. You don't do blood tests for all patients who are getting treated with osteoporosis. They're used kind of very specifically, because in certain medications, you want to utilize what is called as the anabolic window. You want to improve the bone quality before the cyclic catabolic lift occurs. That gives us about 18 to 24 months of the medicine use that actually makes a difference to the bone, increases the bone. Classic example is teriparatide. How do we, what are the blood tests that we do when we have a patient coming in who is completely naive to our clinic, our osteoporotic clinic? What are we going to do for them with blood tests? This is a whole lot of things. There are certain things that I've put in bold because they actually matter for some of our important decision making. Very, very importantly, creatinine needs to be known, because a lot of our medications sometimes can be contraindicated in patients with reduced creatinine clearances. Obviously, if somebody has a low vitamin D, it has to be treated. That's the reason that we do these tests. The baseline DEXA scan has to be done. And then the review tests. We review the creatinine whenever they have a blood sample taken. And every 2 years, do a DEXA. Why not every year? I mean, it's very simple. The sensitivity of the test is such that the test is unable to pick up a statistically significant difference if the time gap is less than 2 years. That's the simple point there. How do you reduce fractures? You see, being orthopedic surgeons, we are desperate to reduce fractures. How do we reduce falls? How do we improve osteoporosis? That is the sort of two-pronged approach that we follow. And within that, there are various other strategies that we address. This slide kind of covers all of that. Anti-resorptive therapy, classically bisphosphonates, reduces bone turnover, stabilizes the microarchitecture that's already there, and therefore reduces fracture risk. But this cannot continue indefinitely because too much of anti-resorptive therapy makes the bone brittle like marble, and then it cracks very easily. So therefore, if somebody is on an anti-resorptive, let's give the bone a break, a breather. We want bone to remodel again, so that whatever microfractures do happen, they have to heal. Otherwise, microfractures propagate, and then you get a stress fracture. Or in this case, you will find those, very linear horizontal fractures in the subtrochanteric femurs, and then you're back to square one. Anabolic therapy increases bone turnover, and this is where that anabolic window that I described a little time ago is very important. That is, at the end of the day, you will actually increase both the anabolic phase as well as eventually the catabolic phase of the bone turnover. It is that lead that you get, that 18 to 24-month lead that you get, that you're actually building bone, and that is the secret. That's the gold that you've got to focus on. And once you build bone, well, you have to ensure that it stays there. We'll get to that in a moment. Now, this is the sort of interplay, and this has been studied time and again. That is, people say, let's give an anabolic therapy first, and then we give a sequential resorptive therapy. That has always stood the test of time. But, humans are impatient. Why not give, teriparatide? We start off with that. And then 3 months later, why don't we start with, let's say, zoledronic acid? Why not? People have studied that. And when you compare the results, it's not very different. It only adds to the complexity. So at the end of the day, if you are keen on opting for a sequential use of anabolic regimen followed by a anti-resorptive after that, good to go. If you want to use anabolic and anti-resorptive more or less concurrently, that's also good to go. It's just that it makes your life more complex. Now, to put down into a nutshell what works where. This is an excellent summary. If you want the reference, it's there towards the end of the slides. This is an excellent summary where literature has proved to us that even if you give good old calcium and vitamin D, you're able to prevent fractures. That's a key take home. Even if you didn't do anything else, if somebody received only calcium, vitamin D, and of course did some decent exercise, their bones get some degree of protection, especially non-vertebral fractures and hip fracture areas. Vertebral fractures, not so much. Bisphosphonates works in all locations, especially the modern bisphosphonates, alendronate, risidronate, zoledronic acid. None of us use ethidronate. I mean, that's sort of historic issue. Palmidronate, only pediatric use. Teriparatide. This, again, very good data to support its use in both vertebral as well as non-vertebral fracture situations, prevention of further fractures. Now, the question of hormone replacement therapy, I'll get to in a moment. Again, this is very intuitive. This is a slide which kind of encapsulates what are your basic concerns with regards to each of these, what are the typical dosages, and what should you do when you're using them. In summary, when you're using a bisphosphonate, the tendency for improvement at multiple sites is great. With HRT, it's again fairly good. teriparatide are also good, and SERMs as well, fairly okay on the vertebral side. Now, with regards to hormone replacement therapy, it was proved nearly 25 years ago that when women took HRT perimenopausally, there was an improvement roughly to the extent of 35% with regards to hip fractures and vertebral fractures and intestinal gut cancers. But what scared everybody based on literature was a sudden jump in DVT and the scare with regards to increased breast cancer and cardiovascular disease and stroke. Now, that has kind of muddied the waters with regards to any recommendation that has been put out there. Now, if you take, for example, the European recommendations, it honestly hasn't changed from around the turn of the century till date. They have not changed it. And they constantly mention these things. Consider other medications before taking estrogen therapy alone or hormone replacement therapy. And if at all you do so, do it at the lowest possible dose, which I think is very sensible. That part is definitely sensible. And for the shortest period of time to meet the treatment goals. They also tend to emphasize that if at all HRT is being used, focus on the fact that the HRT is being used for menopausal symptoms and the improvement on osteoporosis is a secondary goal for them. That has been the way that they have worded it. But I think there has been recent literature that tells us that that actually needs to change. And this is, of course, the British Menopause Society, which urges the change. And I think their emphasis is this: effective, safe, inexpensive treatment, and in selected patients is probably going to be the gold standard in future. That's the summary, and I think that is the way forward, provided that the safety goals are also addressed. Now, I'm going to skip this SERMs because honestly, it doesn't really figure in a large number of our patients, except that when co-indicated for a patient with breast CA, it probably would make sense. The follow-through with treatment is critical. Whenever an anabolic medication is used, please follow it up with something that prevents bone loss. Typically, bisphosphonates, denosumab is the next option, especially in people with low creatinine, with poor creatinine values. The only difference is that denosumab is going to be every 6 months forever. Bisphosphonates would be once a year for 3 years, and then you give a drug holiday, and then you go back to once in a year. In summary, it's a silent problem, osteoporosis. It's a high volume problem. We honestly don't know numbers. How many of us have osteoporosis? Multidisciplinary work is the way to achieve success when we are dealing with a patient with osteoporosis. No one individual is capable of having all the information locked in our heads to be able to deal with this problem. Fragility fractures from our side, from the orthopedic side, is sometimes a nightmare. It needs surgical technique adaptation, and that's a separate discussion, Secondary prevention is extremely important, and I think it doesn't matter really whether the secondary prevention is done by the orthopedic surgeon or the geriatric person or the person who's meeting the patient from the from the family physician perspective or the obstetrician gynecologist. Somebody needs to start the secondary prevention, and whoever does it, thank you. The three givens are counseling, oral calcium and vitamin D supplements, and of course, exercise. Assess benefits and risks, and then let us start with appropriate medications. The high risk factors are reviewed over here. The question of how do we screen, it's with DEXA, and the assessment of risk is with the FRAX score. The calcium that we require every day is 1.5 grams. We believe that our diet gives us roughly 1 gram. So therefore, most people would require 500 milligram supplements per day. This is all calcium carbonate equivalents. Okay. Now, for those who can't tolerate calcium carbonate, at least thank God, in today's Indian market, we get calcium citrate malates. And we do get other chelated calciums, but the cost doesn't justify the potential benefit. The vitamin D is very clear. And remember that calcitriol is not really required for a renal competent patient. Assess risks and then decide whether bisphosphonates are good for them. Is that enough? Do you need HRT? HRT works best in the first 10 years after menopause. Its use after, let us say, after age 60 is a bit iffy. And I think even the sort of gynecological societies haven't really come out too much in favor of HRT post age 60. Teriparatide is great when used for about 2 years at best, and denosumab has its own uses as an independent standalone medication and definitely post teriparatide. A few literature points. This is a great guideline, which unfortunately has been updated on multiple fronts, but the HRT front hasn't. The NOGG has the same issue. It hasn't officially really changed its stance on hormones thus far, but I suppose it's getting urged to do so by other teams. And this is, of course, our own very Indian recommendation, which is there. And this is what I was telling you. This is a great basis to keep in your drawer. If you could print this out and keep in your drawer in your office, it's a great quick reference review, this one, and this as well. I mean, agreed that this is from the orthopedic surgery team, but then it's a great summary of the medical management of osteoporosis. Thank you very much, and kudos for organizing this program. Thank you.
Thank you, Dr. Shankar, for such a nice, precise, compact message from you as an orthopedic surgeon for this very prevention and treatment of osteoporosis. Now we open the session for discussions. There are so many stalwarts sitting over here. I think they would be having some questions. They are invited.
I do hope I'm competent enough to answer some of them at least. I will endeavor to answer them to the best of my knowledge. Thank you.
I will just suggest that the audience should not be misled by Dr. Shankar's modesty. I think he is very proficient in his surgical skills and extremely, very insightful about bone health in older women. Time and again, we have resorted to his expertise for our patients as well as our academic sessions. So thank you, Shankar, very sincerely for having joined today.
Just one question, Shobha. One question.
Yeah.
Yes,
Yes,
sir.
madam.
Teriparatide, suppose 2 years or 1 year goes over, and is it advisable to repeat it after 2 years or 3 years, sir?
Right. Now, see, the question is, teriparatide, if it is being used for somebody who's osteoporotic, typically the trigger factor or indication for teriparatide is severe osteoporosis. It is not just osteoporosis with a DEXA score of -2.5 and that's the end of it. So they typically should have either a pre-fracture situation where they've got a high risk of fracture based on fracs, or they are actually recovering from a fracture. Then automatically osteoporosis as defined by DEXA plus a fracture, an osteoporotic fracture, is a high-risk scenario and that needs to be treated appropriately. That usually means an anabolic agent is most often required. Now, remember that obviously these medications can be used only in renal competent patients. People with low creatinine clearance can't be given teriparatide. That's that. Now, teriparatide in these scenarios should be used or should have been prescribed for 18 months minimum, and the recommendation is 18 to 24 months. The reason for that little laxity on whether it's 18 months or 24 months, A, has to do with cost. Remember that teriparatide is not exactly inexpensive. B, the discomfort of a daily injection every day. Nobody really likes a daily injection. So if we are able to achieve a fairly good improvement by 18 months and cement that into place with, let's say, bisphosphonate, then the job is done. Now, to answer your question about can teriparatide be used again? Yes, at this point in time, there is a revised guidance on that. Earlier on, the British guidance was that the net exposure to teriparatide should cease at max 3 years. Okay, that is a lifetime exposure, net 36 months. Now, there was literature that was studied which looked at animal models where, see, you have to understand why this recommendation came. That's because in the early years of use of anabolic medication, there was this great fear of whether this anabolic medication can result in osteogenic sarcoma. Okay, that's the real foundation of the fear. So we have to remember that at some point in time during the preclinical studies of teriparatide, there was one study done in lab rats where they were exposed to, I think, 20 times the clinical dose of synthetic teriparatide, and then some small number of those rats developed osteogenic sarcoma. Okay, now that was the seed of that fear. Now, thereafter, using therapeutic doses of teriparatide in animal models, in multiple mammalian models, they have gone ahead and showed us that when it is used for practically the whole lifetime of the animal, there is no significant change in that risk of osteosarcoma. Therefore, this initial 36-month limit that was initially placed has been withdrawn. And so therefore, if somebody comes back to us, typically there would be patients with secondary osteoporosis, people who are constantly on steroids. My classic rheumatoid patients, right? They're by the time they're adults, their DEXA scores are barely decent. They're barely minus 2.5. By the time they're 35, they're at minus 3, minus 3.5. By the time they're 50, I've got a lady who's minus 6. Okay. And
Actually,
she's
my
been on
patient was
teriparatide
asking, she has had
repeatedly.
goes, she wanted to have any maintenance course like that on teriparatide.
Teriparatide is not maintenance. It is purely therapeutic. So if you're giving teriparatide, it has to be highly monitored. Not by doing this test and that test. It is about making sure that they use it for that period and then stop, because it's not required to go on with that. So give it for 1.5 years or 2 years. Give a bisphosphonate, for example, and then see how the DEXA behaves. If the DEXA is again dropping, then it makes sense to use another burst of about a year or year and a half of teriparatide. So the way that we explain this to patients is build bone and then you use bisphosphonate as French polish. It seals the bone so that it doesn't become osteoporotic again.
There is a similar question, Shankar, about denosumab.
Yes.
Is it used for, how long can it be used for safely? That is what.
Denosumab is recommended to be used lifetime. So the
That's what.
pity is
Yeah.
that if denosumab, denosumab, let us say, is used whatever 60 mg subcutaneous every 6 months. We do have patients who kind of had stopped using denosumab after, let us say, 2 years or 3 years, because the initial recommendations for denosumab in India weren't really very clear. So we start seeing that the bone density literally drops off. It literally falls off a cliff, attack, and then they're back to being osteoporotic or worse, or they come back with a fracture again. And the reason for that is denosumab, unfortunately, needs to be there all the time. And which means that once somebody gets on denosumab, basically they stay on denosumab every 6 months and carry on. So therefore,
But there is a
I'm not
certain trigger
very
point,
easy to put on
for
denosumab.
Yeah. There is some trigger point for denosumab. So
Yes.
obviously, if we don't put them on that also, the outcome is fairly poor, right?
Yes. So the idea is that denosumab is not going to be used for all and sundry. People who are happily walking, talking, running around with no osteoporotic fractures, with low risk of osteoporosis, they are not candidates for denosumab. I think that's the whole point of that, last couple of slides, that it's important to assess risk benefit. And I mean, in today's world, cost benefit. So maybe it's a tripolar discussion, cost, benefits, and risk. And we have a discussion honestly and then say, okay, listen, here is somebody with osteoporotic situation. They are not candidates for other classic anabolic agents. They've got chronic renal failure. They need denosumab. 1. 2, poor DEXA scores, high risk of fractures on fracts. These are the patients who really need denosumab.
Okay. I just, Reena, I will
Yeah.
just go ahead and share my screen to show the latest directive of in our menopause,
Yes.
journals. So I think without wasting time, no, that's because I wanted Shankar's opinion on this, because we can't hold him on for too long. So this is the latest one, and I thought I will put it off here so that we can discuss it, because this is what is coming as a pop-up now whenever we try to read about the value of the treatment of osteoporosis in postmenopausal women. So this is February 2025. I hope my screen is visible, right?
Of course it is.
So this
Yes.
is extended
Visible.
interval dosing for zoledronic acid. So I just wanted to ask you how many of your women are doing well on this? Are you using this on a regular basis? Yeah.
Yeah, we are using Zol fairly regularly. It's honestly my go-to drug when when it's A, indicated, or B, their kidney function is good, and they don't really need an anabolic agent, then that's fine.
It's fine.
We've been following uh, a regimen where they get Zol 3 years, and then they get a drug holiday, and then
Correct.
they go back to using Zol thereafter. So, if you take 5 years as a cycle, they're basically 3 years on, 2 years off. That's one way
very
to
nice
do it.
to hear. See, because here they have mentioned 1 to 2 years, administered every 1 to 2 years. So I was feeling good that it is once in 2 years. It's a very expensive drug. This is
No,
an
it's not.
expensive
It's
drug.
not very expensive. It's just that you need to be sure about what you're giving your patient, because
Okay.
Zol is available as 4 mg and 5 mg. 4 mg is typically used by the oncology people, and they typically use it twice a year, sometimes even once in 3 months. Breast CA patients and all that, and for men, prostatic CA. Prostatic CA once a month, because you want to shut down, all bone mets. So it works wonderfully.
Correct.
But those are 4 mg. Now we need 5
Correct.
mg because that's the osteoporotic treatment dose, and it is
Correct.
once a year at best. Now, you see, there's a lot
This
of
is a
conflicting literature about once a year versus
Yeah,
once
that
in
is
2
what
years.
I just wanted to bring this, because this is particularly mentioning that it is a longer dosing interval which has been evaluated, and it is 5 milligram once at baseline only, and once at baseline and again at 5 years. Once at baseline and then again at 5 years.
Yep.
Versus placebo in 1,000 plus ladies, and they found that who received 1 or 2 doses had a lower incidence of morphometric vertebral fracture compared with those who received placebo. So both regimes seem to be, working well. That is what I'm trying to say, that can the interval be increased is all that I'm asking you. That's all. Yeah.
Probably yes, and definitely in patients who are requiring bone protection rather than people who are part of your secondary prevention.
Okay, then let her come and get admitted. Thank you very much. Okay. HB on note kumbudu. Mona webinar ya Pratibha. Okay.
So can I ask one question?
Shobha,
Dr. Shankar, can I ask one
just,
question?
Yes,
I'll
Dr.
just
Sudha,
stop
please.
sharing for the present. I'll just stop sharing. Yeah.
Dr. Sudha,
Whether you
yes.
ask first, then I'll ask.
so I just needed to first congratulate Dr. Shobha for roping in Dr. Shankar. Dr. Shankar, I really,
Thank you very much.
want to, say just one word. I have, it's a subject which is very close to my heart, and we've been discussing osteoporosis like anything every forum. And we have been inviting orthopedic surgeons. It was a non-orthopedic presentation of osteoporosis. Believe me, in the process, I have learned so much. I was thinking that I don't know anything about osteoporosis. Believe me, it was such a, crisp, very clear with evidence-based and updated
Very
evidence.
clear. Very good. Excellent.
Number one. Just one question. 65-year-old female with osteopenia and a family history. Mother has had 2-time hip fracture. What do you think? Zolandro is the best option
No,
if she doesn't
I would
tolerate?
first put her through the fracks. See, when you put them through going by a DEXA and family history alone doesn't help
Yes.
us. Put them through the
Okay.
fracks, and that will give you a very clear assessment of fracture risk. Okay, now I know that all of us share a gut feeling that here is somebody who's, let us say low BMI, family history is suggestive of, like you said, mother has had 2 hip fractures. She's a diabetic, maybe under good control. There are various
She has
other things.
nothing.
There are various things that you clinically are putting inside your mental assessment of the whole thing, which tells you that here is somebody who's at a higher risk. Okay, that's ringing bells for you. I would request you to plug those things into the fracks. Put it on your, in your desktop computer or your laptop, whatever you keep in your clinic. Put it on, as a shortcut for the Frax. Nowadays, I call it Frax Plus. I honestly don't know what the Frax Plus is. For me, it's the same thing. You put in the data there, you get your assessment out of it, and then you know objectively whether you have made the right decision there. I'll tell you why. Because we should never be over treating. In our enthusiasm to treat osteoporosis, there is absolutely no reason for us to over treat. Because apart from the fact that calcium and vitamin D itself has got some small but significant side effects. Small, honestly, they're small. So calcium vitamin D itself has got problems. If you now add, let us say, zoldronic acid or let us say alendronate, you've got potential problems on your hands if they were not justified in the first place. So I would, always be a little careful to make sure that you document the justification for going up the ladder, because at the end of the day, this is a therapeutic pyramid. Everybody gets counseling, calcium, and vitamin D, and exercise. That's the first step of the pyramid. The next step is people who are at higher risk of fractures, who've got historic issues that are going to give you increased fracture risk. They need something else. Provided the kidney is working fine, you can use a bisphosphonate for that job. Because here you are dealing with an osteopenic patient, 64, 65-year-old, maternal history of fractures or elder sibling history of fractures. These are the varieties where you are justified in using a bisphosphonate, but it's a good thing to document it. If you put down saying that my frac score for this lady was such and such at this date, you are, so much safer. Because your frac score looks, for example, what's the BMI of the patient? That has an impact. Because like I was mentioning there earlier, obesity is as much a condition of malnutrition as low BMI. Both are they are polar ends of the spectrum of malnutrition.
Correct.
And we could be normal BMI and still have malnutrition, That's the scary part of malnutrition.
Thank you.
We should have one session on that, yes.
So,
Ma'am.
congratulations, Dr.
Mhm.
Shankar. Very, very well spoken. I do not want to reiterate what Dr. Sudhai just said, but I am reiterating the same words again. But I would like to ask you a very, very personal question. It is for me only. So I used to do a very good exercise, yogic exercises for good 17 years. And then because of Corona, it all stopped. And then during Corona only, I had a very push from front in a lot of crowd, and I fractured my this ulna and radius both, and I had fixation, and I can't say the name of the senior person. Then I got my BMD done. I was walking twice a day for around 8 to 10 kilometers a day, twice a day. I mean, half of divided twice. Still, my left hip bone was osteoporotic. And then I was I took zoledronic acid for 6 months, and I was told to take
Hello?
denosumab. I've been taking that. I feel it was started because of the VIPs.
Oh my God.
They have taken 4 doses already.
Okay, I will give it to you now.
Dr. Shobha, can you mute yourself?
Yeah, sure.
Dr.
Then I will
Shobha, please
take it
mute
later.
yourself.
Yeah.
Dr. Shobha, please mute yourself. Mute
Yeah,
yourself.
yeah.
Please mute
Yeah,
yourself.
Anju.
Thank
I
you,
just
dear.
wanted to alert that the physiotherapist is running out of time. Okay.
Just one
We
Yes,
will
yes,
we will
we are
take
going
Dr.
out of
Anju's
time, so
question
please be brief.
and then Dr.
1
Anju's
second.
question and then we'll change. Yeah.
Okay.
So let's understand this again. So the issue is,
So now I got my BMD done. I'm better.
yes.
But I don't know, as you said, and Dr. Sudha and me have been discussing also my case, that you should not be taking this, and I'm now very confused after
Right.
listening to you.
So if somebody's been on a rankle inhibitor, so denosumab, the question is, when do you stop and when do you get off this bus? So, and very importantly, if you get off
But
this bus, what are you going to take?
I am into weight training and everything, and that is also helping me.
Sure.
My bone mass and my muscle mass have really improved
Sure.
as compared to earlier.
Definitely. So if at all you want to get off this bus of using denosumab, then I think it's valid to get back to using bisphosphonate on a regular basis and make sure that your bisphosphonate follows the drug holiday system. Now, if you're
What is the drug holiday system?
right, so that's what I was alluding to, that if you're taking a bisphosphonate, let us say we are discussing zoledronic acid. At this point in time, what we are following is a 5-year cycle where 3 years drug is on and 2 years no drug. So the 2 years it gets a drug holiday. So think of it as 5 years. Okay, 3 years you get the drug, 2 years no drug. Then again 3 years drug, 2 years no drug. So this sort of cycling is very important to let the bone heal, bone breathe. Microfractures will happen, they have to heal. So that is one issue with bisphosphonates. Now there is literature coming out which tells you that provided somebody is in the osteopenic zone and not in the osteoporotic zone, and their FRAC scores are very well under control, then it is probably justified in using bisphosphonates once in 2 years. Now, this is what Dr. Shobha was also talking about. Now, that is something that you might want to explore and look at using zoledronic acid 5 milligrams, start it, and then discuss about whether it's required once in 2 years or once in a year. You will have to obviously follow it up with appropriate DEXA scans, and please, for heaven's sake, look at your FRAX risk issues as well.
Thank you, Dr. Shankar. I think
Shobha,
the time for
Shobha, you
discussion
need
is
to
over.
share Dr. Shankar's mobile, and
Absolutely.
I
We'll
can
get it.
discuss my case because I'm very
We
worried,
go.
and Dr. Sudha is also very worried about my bones. So we need to really center down to something.
Now we are all worried about your bones. Don't worry, we'll look after you. So, Dr.
Thank you,
Shankar,
Dr.
thank
Shankar.
you a
I
lot.
think
Dr.
we are
Shankar, it
getting
was a
late.
really wonderful
We are
talk
getting late,
and
so
learnt a
we
lot.
go on to the next session. We go on to the next session, which is very
Thank you very
important
much,
and
Shankar. Yeah.
very
You're
interesting.
welcome. Aarti, hi.
That
We-
is prescription writing.
Reena,
And,
that's what. We will take prescription writing after the exercise because I
okay,
think
okay,
she
sure.
is getting late for a cardio appointment.
Okay,
Please give her.
okay.
Please give her. Yeah.
So now we invite the Mrs. Sharda.
No, Dr. Mrs. Arati
Aarti.
Prasad.
Arti
Arati
Prasad.
Prasad. Yeah.
Yes. Now we invite Mrs. Aarti Prasad, and please may we have her CV. Mrs. Aarti. Yes. She is qualified from Mumbai as a physiotherapist. 40 years back, a musculoskeletal physiotherapist, has been a clinician for the past 40 years, runs classes for fitness for over 50 years, has been awarded the Lifetime Achievement Award by Bangalore Physiotherapist Network, and has been awarded Women Achiever Award by Garden City University. So she has got a lot of experience about physiotherapy, and now she is going to tell us about the exercises which we need to do at midlife. I invite Ms. Aarti Prasad, please.
Can we have spotlight on her, Paresh? Is it possible so that she can show the exercises?
Yes.
Is that Aarti?
Ji, that's better.
Yes.
Thank you.
Yeah.
Good afternoon, everybody. That was a wonderful talk by Shankar. And
Aarti, hi.
hi, I know you said hi and I was mute. Oh no, but that was absolutely this. And the most important part, no, I was so heartened when you talked about the FRAX score. FRAX score is something many people really do not know about it. And when I did this osteoporotic course and I qualified myself as a bone therapist, I realized there is a FRAX score that can be done for most of the patients. You know, I go way back. I don't know how many of you all have heard of Dr. Bowdekar. Dr. Bowdekar was an orthopedic surgeon in KEM Hospital, one of the stalwarts of orthopedics. And I remember I went for a grand round one day with him. And then he told me, he said, come make the patient stand. I made the patient stand and the patient just went crack and sat down. She broke her vertebral body. Now, this is something very, very commonly we see. And I feel so unhappy that enough importance is not given to exercise whenever we are talking to osteoporosis. So when we are really talking about osteoporosis, I want people to understand that it is not only strengthening exercises. That means, chalo, let's get on to some dumbbells and start moving them, doing it left, right, raising your hands and raising your hands to the side. That is not enough. Shankar pointed out a lot of points about where patients have fractures. And I feel when a patient comes to you with any kind of fracture, especially be it a woman, those are signals which are being given to you saying that in future they can have more osteoporotic fractures. And I think a FRAX scale and a DEXA scan becomes of utmost importance, and people have to realize that this has to be done. Now, when we talk about exercise, we talk about a wholesome program. A wholesome program consists of balance, which is very, very important, especially after the age of 50. Though sometimes I see even younger people losing balance. Balance become a big factor. So we really have to look at their balance. We have to test their balance. And again, we have a scoring there that we can do. Then we have to look at their muscle power. That means it comes into the form of resisted training exercises and flexibility exercises. So it's always a wholesome program. And along with it, of course, we have to give importance to the cardiac. So these are some of the things that we have to take into consideration. And as requested by Shobha, I'm going to go on straight, jump into demonstration of some exercises which I do for my osteoporotic patients. Having said that, the most commonly fractures that we see with women, basically, since we are talking from the Menopause Society of India, we see vertebral body fractures. And there are some of them who are unaware that they've had a compression of the vertebral body. And all that they come is they say that we have back pain. And when you get an X-ray done, then you can see a compression of the vertebral body. So what I'm really going to talk about right now is some exercises which can be in the form of prevention. There's a lot of literature, and what the literature says is exercise becomes a part of treatment in osteoporosis. I just want people to understand that walking, they have done a lot of studies on walking as one of the programs by which the patient can improve. And walking seems to have improved the bone health by 50%. And so walking alone itself, now there are a lot of patients who come to us and say that I walk every day, but walking alone itself is not going to prevent osteoporosis or help completely in osteoporosis. So it is a wholesome program of medication, hormonal therapy, and exercise, as Shankar already mentioned. So what we are going to do right now is I'm going to jump in straight for exercises. And at the end of the talk, if you want me to repeat any exercise, please let me know. So the first exercise that I'm going to demonstrate, one moment, please. The first exercise that I'm going to demonstrate, I hope all of you all can see me.
Yeah, right now we are seeing the ceiling. Can you focus? See?
Not visible.
Just a minute, ma'am. Okay, here we are.
Better. This is better.
Yeah. Can you see clearly now?
Yeah.
Okay. And can you hear me, Shubha?
Yes.
Okay.
Yes, I can hear you.
Yeah. So these exercises, the name of all these exercises is called as growing tall. So that means...
You are disappeared.
Sorry?
We can't see you.
You can see the screen.
No. There's something else is coming.
Somebody's screen is coming.
Yes.
Ma'am, we are not sharing the screen.
No. Somebody's WhatsApp screen.
WhatsApp screen is coming. We can't see you.
What is happening, Paresh? Any problem?
Ask them to tap the... I think it should come full screen, no?
No.
It is coming. You just tap it so that it will
Now,
come
yes,
with the center.
yes.
Yeah.
Now it's coming. And
No,
again.
again gone.
Again it went back.
What is happening?
Tap the top one, it will go.
Oh my God.
Excuse me, ma'am. Ma'am, someone else is sharing the screen. So if we can request the person not to share the screen, that would really be great.
क्या हो रहा है?
Dr. Nilofer is sharing the screen. Can I request Dr. Nilofer to stop
Nilofer,
sharing,
you have
please?
started sharing the screen. Please put off the screen. Yeah, she has stopped. Yeah.
Is it visible right now, ma'am?
It is.
Yes.
Okay.
Yes.
Okay. So we are going to start with this exercise program. Basically, it is called as standing tall or growing tall. So whenever a patient comes to us with osteoporosis, basically, but more so with all the patients who are slightly bent forward, we all tell them to grow tall. How are you going to grow tall? So this is called as the standing foot press exercise. Okay. So
no sound. And its screen has hanged.
Can you hear me now?
Hello.
We can hear. We can hear. We can see also. Yeah.
Okay. So this is going to be, they have to, this is a triangle that they form. The triangle is going to be like this. So they put weight on their heels first. Press your heels down. Then press your lateral borders down. Press your medial borders. So this forms a triangle so that your weight bear completely on your feet. So all the exercises are generally started with this exercise. Bearing weight on your feet completely, you tell them to grow tall. So you tell them to see that as if somebody is pulling the hair. So they grow tall. So this is a posture exercise which is of extreme importance. And then we go to the next exercise, which is called as a scapular retraction. Most of these people, when they have osteoporosis, they tend to become like this. So we teach them something which is called as a retraction exercise. So I'm going to turn Apurva. She takes her hands behind and she pulls the band slightly and retracts the shoulders. So this will be your first beginning exercise. Always start with these exercises. And then you will have them elevate your shoulders. Depress the shoulders and take the shoulders behind. So that you stretch all your anterior muscles, the pectoralis and everything completely, and you tend to become straight. So this is your first exercise. Now we are going to press on the wall. We press on the wall, and she's going to do a push-up on the wall, comes back, and extends the spine. Whenever an osteoporotic patient comes to us, remember one thing, continue to do it. Remember one thing, they tend to go into forward flexion, and that is something all of us want to avoid. So we ask them to do a lot of extension. So always extend the spine. This is another exercise in standing that we ask them to do. Now, another stretch that they can do, which is called as a lengthener. This is called as a lengthener. They go against the wall, lift one hand up, stretch themselves, and they lengthen the spine. They lengthen the spine. That is one. And then they lengthen the spine again. Go on your toes. Very good. Very good. Very good. So these are some of the lengtheners we teach them initially when they come to us. Then you can also add on wall push-ups, and we teach something that is called as wall slides. So they go down on the floor, and then come back again. So wall slides can also be part of the program. Now I will teach one exercise which combines breathing exercises and expanding your chest completely. So we use a lot of breathing techniques, relaxation techniques for osteoporotic program so that they relax a little and then they do the exercises. So the beginning position is this. Take a deep breath. Take a deep breath. Stretch your hands completely. Extend your spine. Yes. Stretch. Very good. And then breathe out. Breathe out. Now you want to progress this exercise. Extend your spine. Lift your legs up. Extend your legs. Up. Extend. Yes. Bring your legs down. And then go down. So these are some of the standing and sitting exercises. I will show you some exercises in the supine position now. Where is the band? So she holds the band in the hand and stretches completely. And this is also causes a certain amount of expanding the chest. So as she does this exercise, she can breathe in and breathe out. The next exercise
needs to be focused a little, Arpi. Yeah.
Can you
slightly
see us?
less focus? I can see in between the focus is going in between. It is becoming blurred and then, but it is seen. It is seen well. Yeah.
Okay. Stretch.
कलर का कपड़ा दे दूंगी वो कपड़ा लगाए या दूसरा कपड़ा लगाए
Please mute. Yeah.
Stretch. And down. Now the other stretch holding, instead of this, they can also hold a a bar. Okay, so they stretch down.
Yeah, it is blurred, Revati ma'am. Slight blurring is there in between.
Stretch.
Aarti, can anything be done about the camera? Slight blurring is there.
Yeah, one moment. Can you see it now clearly?
No, Aarti. No, Aarti.
Now?
More blurred.
Not to put us in the spotlight.
Actually, they have put background blur. Background is clear.
Ma'am, can you remove us from the spotlight? Ma'am, can you please remove us from the spotlight?
And the effect is on, ma'am. So can we remove that?
Remove the blur effect from the background. It will become clear.
Yes, ma'am.
Is it clear now?
They have put us in spotlight. Can you remove us from the spotlight?
Yeah, Paresh, can you remove the spotlight? Then how will we see them? Hello, Paresh.
Paresh, are you there?
कौन help कर रहा है आज?
Paresh, are you there? अभी तो था.
Yeah, now it is seen more or less. You can continue.
Better. Now it is better.
No, I think.
I told Shobha. He is doing. I told him.
Okay.
Can you all see me now?
No, not yet, Aarti. Wait. Okay. What can we do now? She can share. She can share the screen or something like that. And
yes,
what can she do?
Sharing
will not help. No?
The thing is, it's a live demonstration, so we cannot share.
Yeah, that's what. What can we do then? Quickly think of a solution, no?
The thing is, there's some AI effect, that blur effect, which they've put us on the spotlight. That's why the whole video is coming blur. So if you can,
we
unpin.
are individually removing that from our this thing. We are removing the blur part, but
remove from the Zoom setting. You go to the setting and there will be a background. Remove the blur. It will become clear. The people who are recording now, your Zoom setting has to remove it.
हाँ, तो परेश आपको सेटिंग में जाके Zoom सेटिंग में जाके बैकग्राउंड ब्लर का ऑप्शन निकालना पड़ेगा. परेश जी,
Ma'am, is it okay now? Is it seen now?
Now it's clear.
Yes.
Yeah, we did from our phone. Is it okay?
Yeah, it is
Yes.
okay.
Now
Then
we can
we'll
see.
not put the spotlight. We'll see you in that only. That's all.
Yes, ma'am. That would be great. Thank you.
Okay, can I continue?
Yeah.
Okay, so the next one is going to be a stretch with the help of a band like this and down. And believe me, all the patients do it extremely well once they get into the mode of doing these exercises, and they feel so straight and they can breathe better and their pains come down. So what we have done in our department is, as a routine, we have started doing the osteoporotic exercises for all our women patients who come with back pain. So this is another form that we do. And then we ask them to stretch completely and come back. Okay? Now, I will show some lengtheners in a supine position. Always remember, the exercises are started in a supine position and then they are carried forward into the standing position. And after they really get good control of all these exercises, then we ask them to get on to exercises with weights or resistance. So I'll show you another two lengtheners which we commonly do for our patients and the patients really feel much better. So here we go. Stretch your legs. Take the leg up, hand up, stretch it up, and stretch the opposite side. Now remember, when I'm talking about this exercise, this is an exercise which cross stretches. Cross stretch. Okay, so we stretch and leave down. Again, other hand, stretch, leave, and down. Then both the hands up. Stretch the whole body completely. Stretch the whole body completely. Stretch. And hold it and come down. So these are some of the exercise, very minimal exercises I have shown you, which we start doing with our patients with osteoporosis, basically because they all come to us with a certain amount of kyphosis. And then we also always look at their balance. Because if they lose their balance and they are osteoporotic, they either end up with a hip fracture, most probably a Achilles, or they have fractures of the hips. And there are a lot of side effects to all these things. So, but most important, along with your pharmaceutical interventions, I think all of us should come together for a good exercise program that has to be given to the patient. Any questions?
Yeah, I think we'll go to the gallery mode now. We'll go to the gallery mode. Yeah.
Where can we get that stretch band?
Yeah, they're available actually. Resistance band. Yeah.
अमेज़न पे सब कुछ अमेज़न पे मिलता है.
Okay.
सब कुछ अमेज़न पे और डेकाथलॉन.
TheraBand is available, but remember, TheraBand has different resistance to be offered. The ones that are sometimes sold on Amazon, the resistance. It has to be a medium resistance TheraBand which should be used. That is
Echo. Okay. That's wonderful, Aarti. And
thank you.
What I could appreciate is you have told all exercises with a sense of, the patient has to perform with a sense of control and very, very gently. And there are no sudden movements. I think that is where the difference is for exercises for women who are already suffering from osteoporosis. They're very controlled movements. So I just wanted to know that
at the same
duration.
Sorry.
Duration.
When we start with the exercises, we ask them to do 3 repetitions, because the first time when a patient comes to us, we just do not teach them 1 or 2 exercises. It is going to be a gamut of exercises. So it is going to be only 3 repetitions in front of us, and they're going to repeat the exercises once more at home. Only 3 repetitions is each exercise. That is the way.
30 minutes.
Now remember one thing, Shobha. Remember one thing. We are also going to look at their balance. So,
lot of echo is there.
Yeah, we need to incorporate the balance exercises also simultaneously. So there is going to be a lot of interaction that is going to be there.
I think, Aarti, Dr. Anita and Dr. Ragini will agree, and all other seniors also, that we will get you back again for one more session where we talk about balance and other things also. Today's was mainly on osteoporosis and lengthening. One thing which will help us is if you can...
Sure.
If you can give us,
Definitely, Shobha.
If you can give us a summary of... Thank you, Anita. If you can give us The names
just
of the
need-
exercises, na? Wo wale. Because
Okay.
we have a recording. We have a recording.
We can keep
We'll
on
go through
Sunday
it.
morning also, Shobha.
Yeah,
Like we
yeah.
are
We
doing
can.
wellness weekends in the Sunday morning. We are doing
Yeah.
this type of work.
Yeah.
So Aarti, we would like to invite you for that.
Okay. So
Just,
can I take 1
prior
minute?
information
Yeah,
we
Sudha.
give you. Yeah.
Okay. So congratulations, Aarti, for demonstrating different kind of exercises. So what I feel is,
I had given him the link. It is useful
correct
for
me if I am wrong, these are therapeutic exercises for osteoporosis and preventive exercises for fracture.
Yes.
But if we come
Yes.
to preventive exercises for osteoporosis, they have to be little different. They have to be more impactful. And they have to be more.
So now when we are talking about preventive exercises, we start a lot of strengthening. We do a lot of strengthening, looking at their frac scores. Looking at their frac scores, then we start doing strengthening exercises. That is what will prevent osteoporosis. And of course, your
therapeutic for osteoporosis, therapeutic exercises for osteoporosis, and preventive for fractures.
Yes, that's correct.
So thank you, Dr. Mrs. Aarti Radha, for your nice inputs.
We should do? How many minutes we should do exercise? My only question. 30 minutes or 40 minutes?
No, that's what you should be doing only 3 repetitions of each exercise. So by the time you finish, it should come to around 30 minutes easily.
Thank you.
And then you should have the other exercises like walking and everything incorporated inside the program.
Thank you.
Thank you.
Wonderful.
Thank you. Thank you for this
It was
nice
wonderful.
insight.
Thank you very much.
Now I would like to invite, there is some echo, somebody is using 2 devices. Okay. So now I would like to thank Mrs. Aarti Prasad for this insightful, you can say, live demonstration of the preventive exercises. Thank you so much. And we all loved it. Now I would like to invite Dr. Shobha and Goody for the very interesting session on prescription writing.
Yeah, so
writing at the end of the session, after all these inputs, what should be a prescription for a particular person, depending on the case scenarios. So Dr. Shobha, she is right now chairperson endocrine committee menopause, and she has held so many, there is a big list of posts she had held.
I think we'll not do that. We'll not do that, Reena. Thank you so much.
Okay.
And I thank Anita and Ragini for continuously, encouraging me for this program. I'll just quickly share my message is that there is no specific menopause hormone therapy for women with osteoporosis, but we have to talk about it in a holistic manner, because women require that also, along with management of osteoporosis at times. So let me just share, and I'm also going to say that I will not take much time, because we have actually crossed the time of the session. Actually, we are past the time, but that can happen sometimes. So what can be done? So usually I share a Word document because it makes sense about whenever we are prescription writing. So I just want few questions which we can ask when women come in. Of course, we subject them to every type of screening, which Dr. Kurpad so beautifully told. But when the woman walks into the menopause clinic, the one question we can ask is whether she had a fragility fracture of the spine, hip, wrist, proximal humerus, or pelvis. And if the answer is yes, already there is osteoporosis. If the answer is no, is the DEXA score less than or equal to 2.5 at lumbar spine or total hip or femoral neck? If the answer is yes, already there is osteoporosis. So obviously, when we are assessing the risk, we are going to get a DEXA done, and depending on that, this flow chart has been decided. If the DEXA is between 1 and 2.5, -1 to -2.5, then the woman is at risk for fracture based on a risk calculator. And if the risk calculator says yes, there is osteoporosis, no, then it is low BMD osteopenia, which again requires its own management, which we have dealt with in the last session. And if the T-score is more than 1, then it is a normal bone mineral density. Again, in a menopausal woman, a normal BMD that should not kind of make us complacent. They should still fight for it to retain the normal BMD as age progresses, because we all know that bone loss is a kind of continuous phenomenon. Now, when you look at few of the summary and recommendations related to MHT, then we can quickly see some things on eyeballing. It is very clear that wherever there is a fragility fracture, then we need to directly take help from an orthopedic surgeon. Okay, and fragility fracture should not be labeled whenever there is skull, cervical spine, hands, and feet. They are not fragility fracture. The fragility fractures are the ones which are spine, hip, wrist, humerus, and pelvis. Okay, and rib also may be fragility, but it is secondary to trauma. Fragility fractures are those which happen spontaneously. Just like Aarti said, suddenly you find backache and you do a scan, the X-ray, and you find it. Stretch fractures are due to repetitive injury, often in individuals with otherwise healthy bones. And this is how I think we need to caution our women to move from one position to another, sudden getting up, sudden lifting weight. All this can cause stress fracture if there is already osteoporosis or severe osteopenia. There has been enough talk on lifestyle measures already, beginning from Dr. Anita and Dr. Ragini. The fall prevention strategies should be in place. All of us know that. Okay, and weight bearing, muscle strengthening, already told by Aarti. Whenever there is osteopenia, the FRAX score is a must. Okay, and patients with low to moderate fracture risk, no pharmacotherapy is needed. But if the risk is high, then pharmacological therapy is needed. Patient selection for pharmacotherapy, beautifully told by Dr. Shankar, so I didn't want to repeat anything at all. Very wonderfully, he has told us about the pharmacological therapy. And the fracture risk calculation is a must and should be documented always. And the 10-year probability what you get, that will give us a guidance for future therapy. Okay. Treatment decreases the risk of major fractures, including rib fractures, and indirectly it also increases longevity of women in particular. Okay. So choice of initial therapy, again, all this has been already. I'm just bringing it into perspective so that we can finish with the MHT. Okay. Then we have some information here with very good evidence about the bisphosphonates which has been spoken, and the anabolic agents which have been spoken. All right, and those where the bisphosphonates are contraindicated orally, the intravenous zoledronic acid, I also brought in some points, and Dr. Shankar already gave us the current perspective. And then if there is intolerance to that or contraindications to that, for example, renal causes, then denosumab is a reasonable alternative. And who cannot receive any bisphosphonates, then that is what the anabolic agents are, teriparatide, etc. Okay. For most women who cannot tolerate any bisphosphonate, denosumab has been used with grade 2-3 recommendation. All right, that is what. So first, we have to go through this ladder. Whenever there is osteopenia, osteoporosis, but there is no history of fragility fracture, and suddenly we find that the family history of breast cancer is there, or maybe the woman herself is a breast cancer survivor, or she is from Lynch syndrome, raloxifene is a reasonable alternative for improving BMD. When the risk fracture is very, very high, then we have heard about the treatment there, including denosumab, which is a grade 2C recommendation. Well, this information is mostly about monitoring, which he has spoken already, and that there is need for assessment of T-score at intervals. And of course, we make it a multidisciplinary management. So woman attending the menopause clinic also attends the orthopedician and comes back and shares with us the T-score, and we chart it in the menopause record. And that is how we also check her compliance with the calcium, vitamin D, and then also the exercise pattern. We encourage her to maintain a diary of the exercise that she does, and that is how it goes. Now, the general principles are that MHT is an option for prevention of osteoporosis, but we do not consider it as the first-line therapy as of now. Though the data from the white paper on MHT in 2024 encourages us to use it as a primary prevention modality, but we still use MHT mainly for symptoms of menopause and not for prevention of osteoporosis. But yes, women who are taking MHT for menopausal symptoms, they will have benefit of not progressing to osteoporosis or very slowly progressing, but that progress gets retarded. Women who seek MHT for menopausal in their late 40s or early 50s, please note the age. Please note the age. Clearly indicates that early MHT will have the additional benefit of a reduced risk of bone loss and fracture. Now, in them, a separate first-line drug for prevention is usually not required because they are in the younger age group. If they are on effective MHT, then less than the usual dose required for the relief of vasovagal symptoms is actually enough to protect the bone. And that is where is a win situation for the gynecologist. Because if you are giving her, for example, 50 microgram or 1 milligram of 50 microgram per day of the estradiol preparation, actually what is required is only 25 microgram per day of transdermal for protection of bone, or 0.5 milligram per day of oral. So the usual dose of 1 milligram per day is more than enough for protecting the bone. So that is where is a win situation. So if you are using MHT for menopausal symptoms, never forget to tell women that please understand that this is going to protect your bones also, and that may add value to the prescription. Women who desire osteoporosis preventive therapy but do not need MHT, that means they're asymptomatic. So they can have prescription of anti-resorptive drugs, bisphosphonate or raloxifene, as we have already. What about MHT in established osteoporosis? Estrogen not first-line approach, already established. We spoke about it. In women who take estrogen to treat persistent menopausal symptoms, estrogen may be sufficient to treat osteoporosis. So the message here is, if a woman has osteoporosis and is on effective menopause hormone therapy, it is possible to avoid other medications. But what we spoke of, bisphosphonates, but this again has to be agreed upon by the multidisciplinary team. The orthopedician and the expert physiotherapist, everybody has to agree that this is sufficient, and that means that you have to keep testing their scores, T-scores at periodic intervals, and keep them under very close surveillance. Bone density should be monitored in women at high risk for fracture, as another agent may be needed at any given point of time. This is what I spoke. So now let me come to this woman who is 59-year-old menopausal, presents for evaluation of hot flashes. She has all the works of menopause. She has vaginal dryness, dyspareunia, decreased libido. And then we do a DEXA because there is a family history of osteoporosis. Her own BMI is around 23. She has never taken MHT. The DEXA says that she has a low T-score. So she is osteoporotic without having realized it. So actually she should be grateful that the menopausal symptoms have brought her to the menopause clinic. No other comorbidities. We have counseled her, adequately tested her on all counts. We advise lifestyle modification. So in addition to the exercise which I have mentioned here, the walking, etc., resistance training is very important. I've written twice or thrice weekly, but this is for regular. As Aarti already said, probably the resistance training has to be incorporated into the exercise schedule of maybe 30 to 45 minutes as part of the every day, and not twice or thrice a week. Diet, yes, I think we have spoken enough previously. Calcium supplementation and vitamin D, Dr. Kurpad has already spoken. And the MHT which they require to take can be continued up to 60 years of age. 1 milligram of estradiol and 5 milligram of dydrogesterone may be continuous combined, or half the dose of CEE plus 0.5 milligram of dydrogesterone or 200 milligram of micronized progesterone. Please mute. Please mute. So I'm almost finishing. 200 milligram of micronized progesterone. Please remember that micronized progesterone doesn't have a very great, record, not a great evidence for endometrial protection. So I think it is dydrogesterone which will stand the test of time in due course. So let us be cognizant of that. Okay. And then, of course, cross-reference to orthopedician. Time and again, probably every visit she comes to us. So please maintain a very good record for osteoporotic women. As I said already, there's a high value for maintaining the diary, the drug schedule, and frequent testing of T-score. I think I'll stop sharing and we can discuss more. I think other experts will have a lot to say also. Yeah.
Dr. Shobha, very well presented the white paper. I just want to share a few things from the personal experience. Denosum injection is so easy to give, and if we calculate the money spent on other medication, it is not even very costly. And when we compare it with tetraparide and all, they have
teriparatide, yeah.
They have more complication than the denosum, and especially as you also told that denosum is very easy to give in even the patient who is having some renal problem also. And this injection you have to give only once in a 6 month, and you have to continue. यानी कि आपने अभी फ्रैक्चर हुआ और दिया उसके बाद रोक दिया. And second point which I want to focus, that most of us are doing not only menopause practice, a general practice also for the our women. So we should talk about the osteoporosis since reproductive age group of the patient, because that is the time when we put in their mind, if they have more balance in their bank of the bone, only then in the old age they are going to reap it in a good quality of the bone. From my side only, this is the two take-home message to all.
Dr. Shobha?
Yeah.
You've given her estrogen and dydrogesterone. How about giving tibolone in this patient?
Yeah, I think
decrease
tibolone
libido
also, yes. Tibolone is also an option. Yes, also an option. One thought which always comes to mind is it as great as estrogen for PMT? So that is something I have not been able to find. For menopausal symptoms, yes. For menopausal symptoms, yes. But probably it can be used. It can be used if there is absolutely no family history of breast cancer or no personal history.
Yes, and she's less than 60, so
can be used.
People are using tibolone till age 70, 75.
Yes. For older women, it is a. I think when they correct, yeah, it is more.
And recently in the Malaysia, it was a debate. Why should we stop MST at 60? Why not we take forward?
Yeah.
And the person who has presented that it should be taken till at any age was won with a great vote than the other person. who has told no, MST should be stopped at 60.
Yeah.
So his
See,
argument is that
correct.
there's so many type of the MSTs
Hmm.
are there, and specifically older women with no comorbidities, no obvious test,
Yes.
and
No
regular
comorbidities.
follow-up. Why not we continue? And he presented a gynecologist of 92 years, and she was one Asia Pacific Menopause Federation past president, and she is still taking at the age of 92 MST and working day and night in the hospital. So it is also a food of thought.
Yes, true, Dr. Ragini. White paper, which was released by International Menopause Society in 24, clearly says don't initiate at 60. Don't initiate at 60. Don't start at 60. But if she's already having it, don't suddenly stop at 60. See risk benefits ratio and see the other comorbidities and everything put together. If she is, fine, don't stop it suddenly. So that's the white paper.
Remember. Correct.
But don't initiate at 60.
Yeah. Sudha, I remember Dr. Behram Anklesaria speaking on this. And, he wonderfully put the message across that if a woman is doing well on MHT, and she, as Ragini said, has no comorbidities and is ready to follow a healthy lifestyle and is ready to come for follow-up, I think we can continue it for some more time, but revisit the decision every 6 months. Revisit the decision to continue or not every 6 months. So that will give you a control on the situation, and we will not miss any warning signs, right? Like any headache or anything else. So that is important. Yeah.
But here comes the role of SUMS. I think continuing with the estrogen progesterone will be having a more problem than in comparison to the SUMS. We don't have our own study, I can't say.
Yeah. I think we have run out of time now, and
yes,
if
very good discussion. Very good discussion.
Hello.
Thank you so much. Yeah. Yeah. I think we'll take conclusions, and Dr. Anita, if you can conclude, we will say vote of thanks. Dr. Reena is ready with the vote of thanks. So रागिनी ने बोल दिया शायद, आपके रह गए comments. Yeah. Dr. Bipasha is also there. Yeah.
Yes, Shobha, it was very wonderful webinar. Dr. Sharon and Dr. Aarti, they both just narrated everything very nicely, and we have got a lot many carry-on messages. We are knowing everything, but practical implications shown by Aarti was really appreciable, and we would like to take Aarti's I can say workshop-like webinar.
It does very well. Yeah.
Sunday wellness weekends will definitely plan.
Definitely.
Thanks a lot to Dr. Reena also and all the audience, dear Sudha, Bipasa, Anju, and all others joining for this webinar. Thank you very much.
Thank you, Reena.
Bye bye, फिर मिलेंगे.
Bye.
मिलते ही रहेंगे. मिलते ही रहेंगे.
नहीं, Reena is you're muted. Mute है आप. Reena, you're mute. उनका vote of thanks हो गया.
So I would like to thank all of you. So nicely you have attended and you have given so good messages to the delegates and everyone. There were a lot of good take-home messages. Thank you, our President, Dr. Anita, Dr. Ragini, Dr. Shobha, Dr. Shankar, Aarti Prasad, and I can see Dr. Revati, Dr. Sudha for nice inputs. Thank you, everybody, and the delegates who have already attended. Dr. Bipasa is there. Thank you for attending the session.
Padmaja is also there.
Everybody whosoever has attended, it's so nice of you. Padmaja, thank you so much for being here.
Hi, Anu.
Dr.
I
Anu
can
is
see
also
Anuradha
there.
from BMS. Hi.
Yeah, Dr. Anuradha.
So thank you, everybody.
Bye bye.
We'll meet next month on 10th.
And all
Hi,
our
Padmaja.
delegates.
September.
Shalini,
Padmaja,
Ila.
hi.
Thank you. Bye bye.
So we leave now with a good bye-bye.
Again, inviting all of you for physical GCM on 14th September.